fourth session of World Sepsis Congress. My name is Ulrika Knutsson. I'm calling from Sweden. I'm one of the founders of Sepsisfonden, the Swedish Sepsis Trust. We work around awareness and also fundraising money for sepsis research here in Sweden. I'm also the vice chair of European Sepsis Alliance and a member of the board for Global Sepsis Alliance. So I've been working around this topic for many, many years. And I'm really happy to be able to moderate this interesting session around the topic diagnostics and biomarkers in women, children, and neonates. But before I start introducing the speakers, we have a short message from this session special sponsor, which is Biomarker. So we'll see what they have to say first.
Learn about the critical role of diagnostics by visiting Biomarker's Medical Education Hub. Watch webinars and tutorials, access online courses, and download educational booklets developed in collaboration with renowned experts. Go to biomarker.com to begin exploring.
Yes, we will now start introducing the speakers, but I'd also like you to know that you can always put your questions into the comments on YouTube channel in the chat there, and I will moderate it and see and try in the end of every speaker session bring out a few questions. So feel free to do that if you want to, and welcome to all of you from all over the world. The first speaker we will hear from is Evangelos Giamarellos-Bourboulis, my good friend from European Sepsis Alliance. Evangelos is professor of internal medicine and infectious diseases at the Medical School of the University of Athens. And he's also the current chair of European Sepsis Alliance and the president of Hellenic Society of Chemotherapy. But today, Evangelos will talk about embrace biomarkers for a better outcome. So please, Evangelos.
Well, thank you very much for the elegant presentation. I would like to thank the organizers for inviting me. And since we are to speak in this session of biomarkers, the idea is what we need to do in order to embrace our patients and provide them really a better option to meet their needs. Here is my conflict of interest disclosure for the presentation, and I would like to present to you what actually our cumulative knowledge about biomarkers is suggesting us today. The biomarkers can be used in two aspects. The first is to provide what we call prognostic enrichment. In other terms, on exactly the time frame where you measure the biomarker, you need to have the information about what is the likelihood of unfavorable outcome or favorable outcome, the risk of adverse events, and one traditional biomarker which we accept that can do this is a clinical score which we call the SOFA score. The other option is what we call the predictive enrichment. In other terms, on the time moment where we measure the biomarker allows us to understand which is the prevailing molecular mechanism leading the patient to deterioration and dominating organ dysfunction. The data which I present you now is a collaboration between our group in Greece together with the group of Professor Bauer from Germany and Professor Antonelli from Rome. And actually 2 years ago, we presented by splitting a total of 5,503 patients into a discovery set and a validation set that the patients which you may see in each of the circles and which represent the totality of the discovery or the totality of the validation. Inside each circle, you may recognize smaller circles, each of them with a different color, and each of them representing a different sepsis endotypes. The major sepsis endotypes are macrophage activation-like syndrome, the smaller one in green, in blue, the immunoparalysis, and we presented a new endotype in red with the acronym IDS, meaning sepsis, which is driven by interferon gamma. What was really striking, and we identified that in both cases, is that this new endotype driven by interferon gamma can develop in the field of any almost type of infection. pulmonary infections, viral or bacterial, urinary tract infections, abdominal, bacteremia and candidemia. And what happens is these patients is that there is excess production of interferon gamma, which stimulates tissue macrophages for the excess production of CXCL9, which is a chemokine that destroys tissues, leading to organ dysfunction. What was really impressive was that in both the discovery set and the validation set, we recognized that patients who, with this endotype we are in red, this endotype was dominating the outcome of this patient, was leading these patients independently than any other endotype to death. And actually, when it comes to this, the question is, what is the likelihood that something happens to this patient who has a lot of interferon gamma, a lot of CXCL9, and may help the patient to survive? The secret here, and that was the difference between survivors and non-survivors, was that the first 72 hours, the concentrations in the blood of interferon gamma went down, and this decrease of interferon gamma, actually more than 50% decrease, was an independent factor linked with survival benefit. But as I mentioned earlier, in this endotype, interferon gamma stimulates the production of CXCL9. So actually what happened between survivors and non-survivors was that in survivors, CXCL9 went down, in non-survivors, it stayed up, and of course this change was associated with survival benefit. But always in this case, survival benefit is something which prevails in a limited number of patients. And all of a sudden the idea comes, since interferon gamma is driving and priming this endotype and also leads to death, can blockade of interferon gamma improve the outcome of the patients? This is a phase 2 study with the acronym EMBRACE. And this study has just finished. We enrolled adult patients with pneumonia or abdominal infection or pyelonephritis or primary bacteremia, meeting the sepsis 3 definition, all of whom, by using this predictive enrichment of a combination of 3 biomarkers, increase of interferon gamma, increase of CXCL9, and also HLA-DR, more than 8,000 receptors per monocyte, determining that this is a pro-inflammatory endotype, to receive treatment either with placebo or emapalumab, and using for outcome tools of prognostic enrichment, mainly the decrease of the SOFA score and the decrease of the effector molecule, which is CXCL9. Look exactly what we did in this trial. The patients could receive from 1 to 9 doses of the active drug. The drug was given at intervals of 72 hours, and patients could be randomized to treatment with placebo or to treatment with what we call the low dose of emapalumab. That means on day 0 to receive a dose of 6 milligram and the rest of the days 3 milligram, and what we call the high dose of emapalumab, meaning the first 3 days they receive 6 milligrams per kilo followed by 3 milligrams per kilo. Exactly because emapalumab is of crucial importance, interferon gamma is of crucial importance for the innate immune defense, we were monitoring the patients so that in case there was either a drop of CXCL9 or a drop of HLA-DR, the study drug was stopped. With this approach, we ended up from a screening of 502 patients to randomize 75 patients, 25 to treatment with standard care plus placebo, another 30 to treatment to standard care and the low dose of emapalumab, and 20 to treatment with standard care and high dose of emapalumab. The first teaching, which in our opinion was the most important so far, what I presented to you earlier regarding the frequency of this endotype, which here you may see that in red, is an index of prevalence. That means we used a biobank coming from Italy, Germany, and Greece to develop the endotype. Here, over the time, with a study having the characteristics of the incidence, we managed to answer to ourselves to the question, what is the real incidence of this endotype? And the incidence and the prevalence were exactly the same. It was 20%. That means 1 out of 5 patients in our ICUs with sepsis has sepsis which is driven by interferon gamma. And immediately, let's see a bit the characteristics of this patient population, which they were at an average age of 75, with a SOFA score around 10, with a patch 2 around 20, the majority under mechanical ventilation, and also patients with a lot of comorbidities. The primary SO endpoint was the change of the SOFA score. And here I present to you the change of the SOFA score between the 3 groups as heat maps. What exactly do these heat maps represent? In each heat map, you see that there are vertical lines. These vertical lines represent the days of follow-up. And there are rows. Each row is a different patient. And the SOFA score in each of these lines is colored from very light to dark black. And when you switch into dark, that means that the SOFA score goes up. And from the moment the SOFA score reaches 24, actually, a patient has died. What we recognize immediately by comparing the heat maps from left to right of placebo-treated patients, low-dose treated patients, high-dose treated patients, is that the representation of the dark SOFA score goes significantly down in the high dose, whereas there is a prevalence, an increase of the light lines in the high dose, suggesting improvement of the patients. If we would like to switch to survival follow-up, we will end up that the mortality in the placebo group was 52%, 53.3% in the low dose, but 40%, meaning 12% down in the high dose emapalumab. But what is really striking is that someone could say that several times may happen just by chance. And the real way to verify if that was a finding by chance or a real benefit for our patients is actually the long-term follow-up until day 90. And all of us who are working in the field, we know that what is survival benefit by day 28 in the vast majority of the trials is lost by day 90. Here you see that this is maintained, and this benefit, which is 13% on day 60, ends up by being 12% by day 90 and is maintained constant, a 12% survival benefit as the high dose emapalumab is compared to the placebo group over all the days of follow-up. However, what is important if you achieve an effect is if the achievement of an effect is not in order to be certain that this is clinically robust, that this is clinically meaningful, that this is reflecting an improvement of the pathophysiology of the patients. What we see in these curves is the time until decrease of CXCL9. And the pharmacodynamic target was an at least 40% drop of CXCL9 from baseline. Why we selected this 40%? Because this is associated with survival benefit. And you see that at aim 0, there are no differences between groups. But look, impressively, the red line of patients treated with high dose of emapalumab, how fast it goes up and right, meaning that there is a decrease, a substantial decrease of 85% of treated patients with high dose compared to only 24% of placebo. And this represents, by using Cox regression analysis, a fascinating statistical significant difference between the placebo group and the high dose group. If you ask about most frequent serious treatment emergent adverse events, the study was governed by a data monitoring committee, and there were no serious adverse events reported as probably or possibly related to the study drug, and no serious unexpected severe adverse events. So I would like to summarize about a new approach of how to use biomarkers to embrace our sepsis patients and to improve their outcomes. First of all, there is a new endotype involving 20% of total of the patients. An endotype driven by a pro-inflammatory pathway, in which pathway there is no apoptosis and no drop of HLA-DR in the blood monocytes, in which interferon gamma is increased, CXCL9, which is the effector molecule, is increased, and treatment with emapalumab high dose improves organ dysfunction. The relative improvement in the high dose was 41%. This improvement was not shown in the low dose emapalumab. This improvement of organ dysfunction was associated with an absolute 12% decrease of 28-day mortality, which is maintained until day 90. And we managed to present to you today the mechanism of how this survival benefit was produced. The blockade of interferon gamma led to a significant absolute decrease of 61% of CXCL9, 61 difference in the patients receiving treatment between the high dose group and the placebo group, and this was effectuated without major safety concerns, opening a new window of hope for the global management of sepsis. Thank you very much, and I'm looking forward to the discussion.
Thank you so much, Evangelos. I've looked at the YouTube channel here. We don't have any question there, but I do have just a question around, this is super interesting. And I was wondering about this drug that you're tried out. So how is the sort of, what will be the next step, introducing it maybe on the market, or what will be sort of the next process in this?
Well, thank you very much for this. This is actually the substance of the matters. Our goal now is there is a consortium of investigators throughout the European Union, involving actually all big countries of the EU. And all of us, we are planning to start this year a pivotal phase 3 trial after receiving scientific advice by the European Medicines Agency, in order for this 20% of the patients which they have sepsis and organ dysfunction, which is driven by the excess production of interferon gamma, to improve their outcomes by delivering emapalumab and meeting their needs.
Right. Okay. So maybe not so far away then. Hopefully.
Well, this is our target. There is a large group of investigators with a lot of enthusiasm, and what we are committed to the scientific community, that in a pure academic way, we will do our best to meet this vision.
I think it's also great that it's a collaboration between different different countries and different researchers from all over Europe. That's really a hopeful sort of a scenario for the outcome, I think.
Well, if I may comment, the key message here is that this is a consortium which is academic, which is driven by pure scientific enthusiasm. And I believe that if we manage to, and the end outcome is positive, it will be a proof in overall and a scientific paradigm that academic researchers on our own, we can make it.
Yeah, no, that's very true. Thank you so much, Evangelos. Please stay with us. Maybe there'll be some questions later on in the chat. So we will continue our session here with Birgitta Gleeson from Switzerland, from FindDX. Birgitta is an expert in diagnostics, and she leads the organization's AMR portfolio at FindDX, focusing on the development and implementation of new diagnostics for low and middle income countries. And Birgitta, you will talk today about diagnostic solutions for neonatal sepsis in low low and middle income countries. So please welcome Birgitta.
Thank you, Ulrika, for the kind introduction. Yeah, so as you said, today I'm going to be presenting on diagnostic solutions for neonatal sepsis with a focus on low and middle income countries. So I'm not really going to focus on what's happening now in terms of the diagnosis of neonatal sepsis. I'm going to kind of look forward and talk about some of the work we've done in relation to developing a target product profile for the development of a test for neonatal sepsis. I'm going to talk about some of the biomarker work we've done, and also talk about how we can leverage point of care technologies and artificial intelligence for the diagnosis of neonatal sepsis in low and middle income countries, because there's a real chance now with kind of the advance in artificial intelligence to be able to leapfrog in countries in places like sub-Saharan Africa. So just to say, there is limited access to diagnostics in low and middle income countries in general, but this is particularly true for microbiology, where analysis of over 50,000 laboratories across 14 African countries was conducted by ALSM and Africa CDC, and showed that actually only 1.3% of laboratories identified to have the capacity to do bacteriology testing. So this includes obviously things like blood culture and also susceptibility and resistance testing. I suppose coupled with that, there is still no definitive single diagnostic test for neonatal sepsis on the market. This is for several reasons, primarily because developing a test for neonatal sepsis is difficult. Primarily because of the developing immune system of a neonate over the first few weeks of life, also the limited sample volume that you can obtain from a neonate, and the complex clinical studies and some of the ethical concerns around doing studies in neonates. Also at the moment, there's still a lack of evidence regarding the market size. So really very little information in terms of kind of return on investment for developers to really take that risk, considering the high regulatory burden to bring a test to market. However, FIND has been supporting the development of a neonatal sepsis, or really supporting the diagnostic ecosystem for the development of a neonatal sepsis diagnostic. We held our first global stakeholder meeting back in 2023, and the main objective of that meeting was really to align stakeholders to really identify the most important use case for a diagnostic in low and middle income countries. And what came out of that meeting was the first draft of a target product profile that we then partnered with the WHO with to develop, which was published last year, and I'll talk a little bit more about that in the next slide. And most recently, we just published an article looking at the potential health and cost impacts of point-of-care testing for neonatal sepsis. This was a model analysis looking at two different countries, India and Zimbabwe, and we were able to show that actually you can reduce neonatal deaths by 70% in the community when compared to standard of care currently. So as mentioned, we published a target product profile with the WHO just last year. The main objective of a target product profile is really to define what an acceptable test must achieve in order for it to have impact. So it kind of defines the key characteristics for a technology to be adopted. And the use case for this was to aid in the diagnosis of neonatal sepsis, not just for neonatal sepsis, but also for infants aged 0 to 59 days. This is quite an extensive document, but I've just pulled out some kind of key characteristics that I feel is really important for the adaptability of technologies in low and middle income countries. Ideally, you would want a test to be point of care. So ideally, you'd want a test to be able to sit within a neonatal intensive care unit or something similar within the ward. So for it to be point of care, it needs to be quite lightweight. So we're ideally something around between 2 and 10 kg, ideally on the lighter side of things. Ideally, it should be battery operated, so not relying on power source, which is not always sustainable in low and middle income countries. And also, if we're looking at kind of more of a non-hospital setting, I think it's important that these tests can be used by non-trained personnel. Ideally, it needs to be rapid, so anywhere between 15 and 30 minutes, and this is due to the high risk associated with not treating a neonate with suspected neonatal sepsis. It needs to be affordable. So the TPP has set quite a I suppose, difficult target of $5 USD for a point of care diagnostic, which we do think is achievable. I think, but importantly, these tests also need to be integratable. So if you can broaden the use case so that the test is not just used for neonatal sepsis, but it's actually used for kind of the overall management of the neonate, then it then makes the test a little bit more cost effective. And I think this is something that's often overlooked when developing a test or when doing cost effective analysis on diagnostics. Ideally, it needs to have a low sample volume, capillary blood with max 100 microliters, but ideally 25 microliters is better. It needs to be high performing. So the modeling that I mentioned in the previous slide actually determined the performance characteristics that a test would need to have in order for it to have an impact. And the limits we set are sensitivity of 95% or above, and a specificity of 70% to 80% or above, depending on the setting. I think also very important, these tests need to be developed for use in low and middle income countries. This is particularly important given the population and the geographical spread within low and middle income countries, but also it needs to be developed with the environmental considerations and the robustness needed for the use of tests in low and middle income countries. So we have done a systematic review of studies to evaluate the performance of biomarkers. We looked at over 113 neonatal sepsis studies that included over 20,000 neonates over a 10-year period. And we mapped this against the sensitivity and specificity criteria that was defined in the WHO TPP. And what we find is that actually very few single biomarkers meet the TPP WHO cutoff. So if you see here in this top right-hand side quadrant, these are any of the biomarkers that actually meet that criteria. So we can see that the traditional biomarkers like CRP, PCT, and IL-6 actually don't meet that TPP cutoff. However, there are some interesting biomarkers such as estrone and presepsin that can potentially meet the cutoff, but at the moment there are no point-of-care diagnostics available for these biomarkers, but they are definitely of interest. So our solution or our thinking really based on this was that this needs to be more a combination of biomarkers and other clinical routine data, such as complete blood counts and vital signs. And I think this is potentially possible now with the advancements in AI. And obviously we have scoring systems that perform quite well, but our thinking is that you can augment these scoring systems to be able to make them perform better to try and reach those sensitivities and specificities outlined. So our thinking is really a kind of more around developing a multimodal point of care diagnostic solution for neonatal sepsis in low and middle income countries. So the idea being that you have a neonate with some sort of clinical suspicion, so mild signs and symptoms or risk factors. And then you use this what's called a risk stratification bundle. So you would take a sample from the neonate, ideally a small sample from a neonate, and then you would use it to analyze biomarkers like the traditional PCTs or IL-6, however, in combination with something like a point-of-care vital signs monitor that's got the capability to monitor, let's say, heart rate, respiratory rate, oxygen saturation, and temperature, and then also combine that with a point-of-care hematology analysis of things like white blood cells counts and their differentials. And then obviously feed this into kind of an AI risk-based algorithm, which would then give you an idea of risk in terms of the neonate developing sepsis. And we do believe that point-of-care technology has the potential to meet the WHO criteria, both from an affordability standpoint, its turnaround time, its requirement for small volume, and also in terms of its performance characteristics. So I did want to originally present a landscape of technologies that we thought could be potentially feasible that would kind of fit this kind of risk stratification algorithm. However, due to the limitations in time, I just cherry-picked several technologies that I think could potentially be used, but this is very much an example and it's just for illustrative purposes only. And I don't endorse the use of any of these technologies as such. They're just merely to be here as an example. So one example would be if you had, let's say, a handheld fluorescent immunoassay like this one here developed by Biopanda. It has the capacity to analyze CRP, PCT, IL-6, and serum albumin A, which is recently become quite a promising biomarker for neonatal sepsis. These have a turnaround time of anywhere between 3 and 15 minutes. It's lightweight, 1.5 kg, can be used with capillary or heel stick blood, can be used at the bedside. I suppose one of the drawbacks of this is that it is singleplex, so you do need a separate lateral flow assay for each of the different analytes. Which means that potentially you may not meet that criteria in terms of kind of rapid turnaround time. However, there are other solutions, and one of these solutions of interest is DiaMind. This is a point-of-care hematology analyzer. It's actually the first hematology analyzer that combines hematology analysis and also CRP and serum albumin A. It has the capacity to analyze 21 parameters, and it uses artificial intelligence for image analysis for the flagging of abnormal blood results. It has a turnaround time of 4 minutes. It's very much one sample, 35 microliters of whole blood. You add it to a buffer into a centrifuge tube, and then you add that to the cartridge, and then you get a quantitative output from the instrument. And then finally, this BioSurfit is very much a true point of care system. It's It's based on microfluidic technology. It's lab on a disc, very, very easy to use. Currently has a kind of a limited menu of CRP, HbA1c, and CBC. However, we do know they are working on expanding that menu. It has a turnaround of 15 minutes. Again, multi-parameter, except obviously one disc is specific to the parameter at the moment. It takes capillary or heel stick blood, and it's currently on the market and quite affordable. Then in terms of vital signs, there are lots of manufacturers working on developing vital signs or monitors for the continuous monitoring of vital signs. Two I've just selected are this Neopenda one, and this is of interest. This is a wearable that goes on the neonate's head. It's capable of monitoring pulse, oxygen saturation, respiratory rate, and temperature. And it's already been CE marked. And really what we're seeing is a lot of these vital signs monitors are now performing just as well as kind of the gold standard vital signs monitors that you would see in an emergency department. The Neopenda system has been developed in sub-Saharan Africa and for use in low and middle income countries. And then the other one I also want to talk about was Civil Health. This is a wearable that goes on the chest or the limb of the neonate. It has the capacity to monitor heart rate, respiratory rate, skin temperature, and others actually that were here at one stage. This is FDA approved for the monitoring of vital signs in neonatal populations already. Obviously, it doesn't have a neonatal sepsis indication as of yet, but this is an interesting technology in that it's point of care. And then obviously, I'm sure a lot of people have presented on this already, the first FDA approved AI algorithm for the to aid in the risk assessment of sepsis prediction, not necessarily in neonatal sepsis, but for sepsis for patients presenting to the emergency department. It uses 22 parameters for determining risk. However, that can be reduced to 10 parameters. So our idea is that you could potentially use some of these point of care technologies to feed into this kind of parameter risk assessment for sepsis in neonates in low and middle income countries, given the development in point of care technologies. That's quite exciting at the moment. And finally, just to say that obviously neonatal sepsis remains a major diagnostic gap, not just in low and middle income countries, also in high income countries, with no single point of care yet meeting all of the WHO TPP requirements. Our thinking is that the most promising approach is a multimodal strategy that combines various different parameters such as biomarkers, hematology, and vital signs. And the existing technologies do show strong potential. However, it's really important for prospective validation within LMIC settings before a broader implementation. And our next steps is really to publish a comprehensive landscape of these point of care technologies that could potentially feed into something like an algorithm. We are also developing evaluation guidance. We identified through our biomarker review that there's lots of heterogeneity in how these studies are conducted. So we want to try and see if we can standardize that in some way so that we can interpret the data more seamlessly from studies in relation to biomarkers. And our plan is to really collect prospective point of care data to support ultimately support an algorithm development. So thank you. Happy to take any questions, and if anybody would like to get in touch with me, my contact details are here. Thank you.
Thank you so much, Birgitta. Very interesting, and I'm just wondering, could you just give us a little quick, so what your organization actually, how you come in, what's your sort of purpose as it were?
So FIND is a not-for-profit organization headquartered in Geneva. Our ultimate goal is to try and improve access to diagnostics in low and middle income countries. So we really predominantly focus on low and middle income countries. So we work with test developers, we work with academia, we work with manufacturers, we work with the regulators at kind of all stages of test development to try and kind of de-risk some of the development of tests. And also in cases where, let's say, like I said, manufacturers are not so clear in terms of return of investment, we would kind of do the background work to ensure that that evidence was there in order to kind of encourage the development and also to, in some ways, to fund the development of promising tests. So our scope is very broad.
It's super interesting. And I'm just wondering, so when you come to that slide with all the sort of different technologies, so what would you say are the biggest hurdles to get those type of technology out into low and medium income countries and to the bedside of those countries?
So, I mean, a lot of these tests are already on the market and they have already been CE marked. I think
Yeah.
the complexity really comes in when you want to use these tests for determining risk stratification for neonatal sepsis. If you were to bring these tests to market on their own, the regulatory burden wouldn't be as high. So really, the regulatory burden would sit with the development of the AI algorithm, not necessarily with the point of care technologies. Really, what you would just be doing is putting a point of care hematology analyzer within a NICU unit, that's already been CE marked. So I suppose you really have to, I mean, the difficulty is really determining where the risk lies within each of those diagnostics to be able to develop an algorithm.
Yeah. Thank you, Birgitta, so much for very insightful talk. We will leave Switzerland and go back to Greece, and I'd like to welcome Evdoxia Kyriazopoulou. I hope I pronounced that right. Greek name are always a little bit of a mouthful. Evdoxia, you are an intensivist at the second department of critical care medicine at the University of Athens. You have a PhD in biomarker guided treatment in sepsis, and your postdoctoral research has been focused on the immune dysregulation of long COVID syndrome. But today you would talk about procalcitonin and if this biomarker has any difference in between genders. So please, it sounds to me like a super interesting topic, because I think quite often we research on men and not always on women. So I'm really keen to hear your talk.
Hi, hello, thank you very much for the kind introduction, and I would like to thank the organizing committee for inviting me to participate in this year's World Sepsis Congress about universal care for newborns, children, and women. Indeed, this is an interesting but also difficult topic, and for the next 12 minutes we will talk about this biomarker, procalcitonin, which is a biomarker produced by the thyroid gland in normal conditions. It is the precursor of calcitonin, but in cases of infection, all mesenchymal cells can produce procalcitonin when they get the stimulus from the LPS from the bacteria. So PCT rises, and we will see if it rises in men and women are the same. We know already that there are differences of the biomarker kinetics by type of pathogen and sites of infection. As said before, the LPS is a stimulus for PCT production, so infections by gram-negative organisms like urinary tract infections or intra-abdominal infections have higher levels of PCT compared to lower respiratory tract infections. And of course, gram-negative bacteremia exhibits the highest PCT levels. We know already that there are differences by neural function of patients with sepsis and also with sepsis severity. Patients with higher SOFA and Apache scores exhibit higher PCT levels, and that is in the most of times correlated with bacteremia, but we do not know exactly if there are differences by gender. A very recent quick 30 PubMed search about the biomarker and gender, I revealed only 450 records, with very few of them being relevant to the topic. This is a nice study from Sweden, quite old enough, a prospective population-based cohort of more than 3,000 individuals from the Malmö. And this study had a median follow-up of 16 years, where men and women were followed up for all-cause mortality and cancer mortality. Men had higher PCT levels than women, and these PCT levels were correlated with mortality, but in women that was not the case. So perhaps PCT correlated with reflected a very fragile profile for men, but not for women. What happens in cases of infection? We know very well that there are different proteomics, different production of proteins in patients with sepsis compared to healthy individuals. And here above there are healthy individuals compared with men with sepsis, and here healthy individuals compared with female with sepsis. So there are many differences in patients and healthy individuals. And all these proteins shown here as yellow circles are the proteins that are either higher or lower in sepsis patients of both genders. There are also some differences. So male patients have higher proteins like AFP or cholesterol is downregulated, whereas women have other specific protein production when affected by sepsis. IL-6 is going up and rheumatoid factor is going down, but PCT seems to be not here in this category, gender-specific biomarker. These are unpublished results from the Greek Progress trial. That was a trial, a randomized trial with sepsis 3 patients, randomized to receive either PCT-guided treatment or standard of care. The trial recruited patients with respiratory tract infections and acute pyelonephritis, and there was a PCT measurement at baseline and after 5 days of treatment. The levels of the biomarker were similar among genders. In COVID-19, which is a prototype of viral sepsis, we know very well that PCT is a prediction biomarker, may indicate these patients that are probably more likely to die. And in this study of hospitalized patients with COVID-19, we see that if the biomarkers, the inflammation biomarkers such as CRP, ferritin, and PCT are higher, those patients are prone to death. But this correlation, this association with higher risk for death is more pronounced for women rather than for men. There are also gender-specific conditions where PCT perhaps may have a role. Such a gender-specific condition is maternal sepsis. Of course, maternal sepsis can only happen to women. And although the rate is going down the latest years, this study, the Global Sepsis Maternal Study from the WHO conducted in 2017, showed that there is about 13 severe maternal outcomes per 1,000 live births. And this rate is higher in regions of the world such as Africa and Southeast Asia. So could perhaps the biomarker help us diagnose and predict maternal sepsis before or early if it occurs? From this meta-analysis, we see that PCT levels in healthy pregnant women that are not in labor and do not have complications are similar to other adults. So if we consider a healthy pregnant woman not in labor, then perhaps the biomarker has exactly the same performance to detect sepsis as in healthy individuals. But women that are pregnant in labor or have obstetric complications even without infection, have higher levels, and here the situation is difficult to diagnose infection only being focused on the biomarker levels. Of course, maternal sepsis affects more the women that undergo cesarean section, and in this study, it seems that CRP has a wide variance of values in the postpartum, in the early postpartum period. So it is not a reliable biomarker to detect maternal sepsis, whereas PCT does not show the same variance, and a cutoff a value of below of 0.25 is a valuable adjunct to clinical decision to rule out an infection in the postpartum period. There are many studies that underline the higher performance of PCT in maternal sepsis compared to other biomarkers such as CRP or WBC, white blood cells, with a sensitivity exceeding 80% and an area under the curve of 0.8. And of course, if we repeat the measurement after 48 hours, then we have a higher sensitivity to detect maternal sepsis. This is a quite old study, which I found very interesting. That's why I wanted to show that. It's a study from 9 women after delivery, and the authors have measured PCT in serum and milk. And of course, PCT in serum was not increased in the postpartum period after delivery, but there was a high concentration of PCT in milk, which was at the highest levels during the first 2 days, and they're declining thereafter. That means that perhaps PCT is produced by breast and is contained in milk in order to trigger the developing neonatal immune system and has perhaps pro-inflammatory reactions. So to conclude, we know that there are differences by type of pathogen and type and site of infection. We know that there are differences by renal function and severity, but we're not sure if there are differences by gender. The evidence is varies a lot, and yes, there may be some differences, but more research is needed to come up to safe conclusions. Thank you.
Thank you so much. It's very interesting, and I think, as you say, I think more research probably should be conducted, because it's also considering if there are difference in protein or biomarkers in sepsis, maybe there's also a difference in how we can treat it. So I think more research definitely should be needed. Are you planning on any more studies in this area from your end?
So there were very few data. I was surprised about the sparse data that exist, and I hadn't thought before on this topic. This year's World Sepsis Congress was an inspiration also for conducting better research.
Yeah, well, wonderful. Thank you so much. We will continue. We will, well, from my point of view, go over the Atlantic and go to Canada to welcome Amy H. Lee, who is from the Simon Fraser University. You joined the Department of Molecular Biology and Biochemistry at Simon Fraser University in British Columbia in Canada as an assistant professor in 2020. And you were also, you have a PhD in cell and systems biology at the University of Toronto, and this was also followed by 2 postdoctoral fellowship at the University of British Columbia. And today, Amy, you will talk about predictive gene signatures to identify neonates who develop sepsis. Warm welcome to you, Amy.
Thank you so much for the invitation. So I think Dr. Gleeson really highlighted the importance of improving diagnostics for neonatal sepsis. What I want to sort of focus my talk today is on that discovery portion of biomarkers. But really, one central question that drives my lab's research is this observation of across the globe that the risk of dying is highest in the first month of life. And to put this in context, for the duration of my talk, which is 10 minutes, about 4 to 5 newborn babies likely die from neonatal sepsis somewhere in the world. So that is a horrendous number to hold on to. And you can also see from this world map that I'm showing you that the neonatal mortality is highest in low and middle income countries. Particularly, these newborn deaths account for about 50% of deaths seen in children under 5 years old. And the risk, the highest risk, is that first week of life. So really, to meet that UN Sustainable Development Goal, where our goal is to reduce neonatal death to less than 12 per 1,000 births by 2030, improving diagnostic is one of the key strategies. So a lot of work that happens in the lab, and what Dr. Gleeson also talked about, are some of these, developing some of these gene signatures or molecular markers from the neonate. So these are considered host biomarkers that can allow us at symptom onset to find infants who may be suffering from severe bacterial infection. So we call these bacterial sepsis biomarkers, in order to, prioritize them for empiric antibiotic therapy and give them appropriate antibiotics, because as we know, it wouldn't work on viral sepsis. And another branch that we work on in the lab is these severity markers, where our goal is to identify those infants who are really, really ill so that we can prioritize and triage them, for urgent referral and where limited resource allocation is critical. And so this work is supported by CIHR. Now, all of this bacterial sepsis markers that we've been talking about, or neonatal sepsis markers that we've been talking about, are at symptom onset. But during conversation with a clinician friend, what we realized, and one really great question is, can we identify those newborns before they are sick? Ideally, maybe at birth, so that we can actually do something about it. Now, in order to answer that question, it's actually kind of tricky, because you will have to recruit a large cohort of newborns, ideally healthy, and some of them will go on to develop sepsis, but you collect sample at birth to do that predictive signature work. But it's very hard to get just a healthy newborn cohort. Fortunately, my group, and also when I was a postdoc, I was a part of this large multinational project where we're developing multi-omics to study neonatal immune development and vaccine response. And this is led by Dr. Alfred Levy at Boston Children's, with Dr. Beate Kempman leading the clinical cohort recruitment in the Gambia and West Africa, as well as Dr. Toby Coleman, who's leading some of the molecular work. And overall, for this cohort, we have 720 healthy newborns. They're term, and we collect whole blood, peripheral blood from these newborns. And there are 720 of them. All newborns have their day of life 0 sample taken. And then they're randomized into day of life 1, 3, or 7. And because we're studying vaccine responses, there's also a combination of different vaccines, which I won't get into in today's talk. But what's actually quite incredible is from that, each infant only had 1 ml of blood. And from that 1 ml of blood that we drew, we're able to perform diverse molecular characterization, including transcriptomic, plasma characterization of plasma proteomics and metabolomics, as well as cell phenotyping and cytokine profiling, all with only 600 microliter of blood. And we still have 400 microliter of blood banked for other work. Now, what's interesting is within this 720 healthy infants, some of them go on to develop sepsis. But because all of them we've collected blood sample at day of life 0, we can actually ask this question at birth and we could call that baseline, is their at-birth molecular signature that allow us to predict those infants who go on to develop neonatal sepsis. Now, you can stratify babies who have neonatal sepsis into early onset sepsis or late onset sepsis, with early onset sepsis typically developing within that first week of life, and late onset sepsis typically later. Now, as one of the requirements for all these infants to be included in this vaccine cohort is healthy term. They all showed up clinically well at their birth sampling. Now, a subset of them develop early onset, 15 infants develop early onset sepsis, 6 develop late onset sepsis, and then we had a control group. We call that the infection group or localized infection group. These are babies who have, say, skin infection, but they're really localized. It did not go on to become full-blown sepsis, and they were treated. And then we randomly selected and age matched a group of healthy infants. From there, we analyzed their whole blood transcriptome. And from this figure, and we perform machine learning on this whole blood transcriptome. And this is work done by Erica Acton in my group. And what you can see in this figure is that the early onset sepsis babies, which are these individual red dots indicated by the red dots here, are separated from all other infants, the healthy in blue, the localized infection, as well as the late onset sepsis, which tell us that at birth, the early onset septic infants are different. And if you look at the gene signature that can separate out early onset sepsis from all these other infants, it includes 2 heat shock protein HSPH1 and DNA JB1. We then work with Dr. Andy Ann, who at the time was an MD PhD student in Dr. Bob Hancock's group. And we further refined this gene signature into a 4-gene signature that has a very high sensitivity and specificity. We perform gene set variation analysis to identify cell cycle and heat shock pathways that are particularly enriched in early onset sepsis. And again, you can see that these genes that we've identified tend to be highly expressed in early onset sepsis, but not in healthy or infants with other types of infection. We validated this independently using published data. And our next steps, is kind of been outlined by Dr. Gleeson. We're really thinking about how do we incorporate all of these different information, including the molecular data, the clinical data, performing AI, and making this multimodal diagnostic platform that can allow us to do faster diagnostics. We are also developing pathogen sequencing strategy to help us further refine that identification of sepsis etiology. And this work, we currently have a cohort in Uganda that's led by Dr. Matt Weens, and funding is supported by Silicon Valley Community Foundation, where we're going to test how well does this 4-gene signature marker work on a much larger cohort. And with that, I just want to thank my group, all the funding that enable this work, as well as this large EPIC consortia that provided the data which allowed us to find those signatures.
Thank you. Thank you, Amy. I was trying to just to understand that the cohort of 720 infants, were they in Gambia? Was that right?
Yeah, sorry.
Yeah.
Yes, they are in the Gambia from in West Africa, and they were recruited 2017 to 2018.
Okay. So what is, I saw the last picture here, but what is your aim, you think, for I mean, what's the sort of end game of this research?
Yeah, that's a $1 million question,
If there
I
is
think.
one.
Yeah, there is one. I think the goal is, we already have a birth screening for lots of different things.
Yeah.
Can we implement this at birth screening for neonatal sepsis so that we can identify those infants before they show any clinical symptoms?
Right. Yeah.
Right? And really prioritize treatment and figure out what they need before they develop full-blown sepsis.
Exactly. And you were talking, I think, somewhere earlier about the antibiotics and how to, I mean, so what are when it comes to low and middle income countries, there might be a problem of the availability of antibiotics. Are there other sort of treatments or measurements that you can use for those kind of settings?
Yeah, so I have other work that's ongoing where we're looking at kind of simple things like L-arginine or arachidonic acid, and try to understand, are there supplementation that we can provide during pregnancy that can potentially improve outcome. But those are still kind of in the recruitment stage. We have animal model work that shows potentially that there's a protective effect. But now we have to kind of translate it to the bigger picture.
So do you mean also that this study could also, when it comes to prevention, like in the pregnant state of before they're born, is there something? You mean there's something you can work on with that too, for prevention of?
Yeah, that's a really good question. I think that is definitely kind of the next stage where we're moving towards.
Right. Well, thank you sorry, Amy, for that fantastic talk. And stay tuned. Maybe there will pop up some more questions. We never know. And we will leave the American side of this and go back to Europe and welcome Chiara Medici from Sant'Andrea Hospital in La Spezia in Italy. Chiara graduated in biology and specializing in microbiology and virology from the University of Pisa. And you are also a committed microbiologist and virologist, and your studies have involved you in residency projects both in Paris and Dubai. And you are currently a resident microbiologist at the Sant'Andrea Hospital in La Spezia. And your talk today, Chiara, will be on molecular diagnostics in child infection. So please, you're welcome, Chiara.
Thank you. Good evening, everyone. And I'm delighted to see you all. I'm very grateful to have been invited to join this wonderful panel tonight. I hope I can make a little contribution. So the title of my presentation, Molecular Diagnostics in Pediatric Infection, and my aim in this presentation is to provide an overview of current and future technologies used to manage infection in pediatric patients. As is well known, sepsis is a dysfunctional response of the body to infection. In pediatrics, it is classified in 3 phases: early and late onset, and pediatric sepsis. In this slide, from a review published in 2024, we see the main microorganism responsible for sepsis in children, as well as the main risk factors. From a laboratory perspective, it is important to define both the timing and the accuracy of the diagnosis through the evaluation of laboratory criteria. For macrobiological diagnostics, the gold standard is still the blood culture, but today there are more sophisticated methods of bacterial detection, such as molecular biology platform and the use of mass spectrometry, the MALDI-TOF. These here are the critical factors in the management of pediatric blood culture. The sample collection, which must be at least 1 to 3 ml, even for very young patients. The short turnaround time, which is a critical factor when drawing the sample. The presence of contaminants, which must be correctly interpreted by the clinician, and the sensitivity of the system available in the laboratory. One of the main benefit of molecular biology is its 96% diagnostic accuracy, which when combined with standard culture-based method for bacteria species identification, allow us to save nearly 24 hours compared to with the standard macrobiology. Another benefit is the ability to de-escalate treatment through optimized therapy thanks to the results of molecular biology. There are, however, limitations to consider, namely the absence of AST, antimicrobial susceptible testing, a non-universal coverage because not all microorganisms are included in this syndrome-based panel, the possibility of false positive arising, and higher cost compared to standard blood culture methods. In our laboratory practice, the workflow for positive blood culture follows a standard diagnostic pathway to detect bacteremia and fungemia. Once a blood culture has come back positive, we perform a gram stain. So what happens next? Well, here's what. If the infection is monomicrobial, we can proceed with the standard culture or directly identify the pathogen using MALDI-TOF and immediately set up a standard susceptibility test or a rapid antimicrobial susceptibility test. If the infection is polymicrobial, the standard method must be used, which involves seeding on selective media and identification using MALDI-TOF followed by an AST. And the time in this case is 48 to 72 hours. In general, molecular multiplex panels can be used, which help guide the choice of the susceptibility test to be used. With the MALDI-TOF system, the positive blood culture is inoculated onto standard medium, and after incubation for between 4 and 24 hours, identification is carried out by mass spectrometry. Alternatively, rapid identification can be achieved using a milliliter of blood from a positive blood culture, which can be centrifuged and spotted under the MALDI-TOF plate. There are several rapid syndromic PCR methods available to us. In our laboratory, we use the Biomarker panel, which covers 43 targets and provides the results in around an hour. The panel detects gram-negative, gram-positive bacteria, as well as yeast, and also identifies resistance mechanism. Another molecular biology system is produced by Halifax. It can be detected up to 64 different targets starting from a positive culture. However, it can only be performed after gram staining. The panels are divided into gram-positive, staph or no staph, gram-negative, and resistance mechanism, providing results within an hour. Another system in use is the Cobas Aplex blood culture identification panels. This system uses 3 different panels for gram-positive, gram-negative, and yeast and resistance genes. The key strength of this method is that it incorporates pan target for gram-negative, gram-positive, and yeast organisms to detect misleading gram-stain microorganisms. Future prospects. We are now going to look at some methods already available to laboratories. However, they present a challenge for standard diagnostics and emergency treatment. One promising approach is to eliminate the weight of the weight for blood culture results by performing molecular tests directly on blood. There are many challenges associated with this type of analysis, namely, circulating organisms during such infection have long been limited by their low numbers, 1 to 10 UCF for ml, the presence of DNA from dead bacterial cells, from clumping cells, and from bacteria engulfed by circulating phagocytes. Large quantity of human DNA which could interfere with the primer and probe binding during PCR, as well as other inhibitors such as iron, immunoglobulin, and heparin. Iron, which is mainly associated with hemoglobin from erythrocytes, and lactoferrin from leukocytes, can inhibit PCR by inhibiting DNA synthesis. Immunoglobulin, in particular IgG, which is capable of binding to single-stranded DNA, can also inhibit PCR. The amount of human DNA can be reduced by removing white blood cells prior to DNA extraction or by employing methods for the specific removal or degradation of human DNA following nucleic acid extraction. This slide presents some examples of methods involving real-time PCR or digital PCR using whole blood samples. The challenge regards both the type of sample processed, as explained previously, and the initial blood volume, which is particularly problematic in pediatric diagnostics, and also the fact that the sample must be taken at the time of a clinical suspicion of sepsis. In addition to next generation PCR, we can use Sanger sequencing and WGS for sequencing of ribosomal genes. These texts allow the numerical limit of the microorganism being detected to be exceeded compared to other methods. Furthermore, they enable the detection of any resistant genes and clonal clusters that may be present. However, they cannot as yet be performed routinely as they require laboratory staff who are highly specialized in the preparation, reading, and interpretation of the results. It is of vital importance that all these methods are employed in the initial clinical assessment of sepsis with the framework of antimicrobial stewardship. In this context, close collaboration between the clinician and microbiologist is essential to guarantee an accurate and increasingly rapid diagnosis. Thank you for listening.
Thank you so much, Chiara. I was wondering, so if I understand, so this molecule diagnostics in children with infection, is it specific? Is there something specific to think about when it comes to children, or is it this sort of the same kind of setup in adults? I didn't quite understand that. So just a question for me.
In general, in our hospital, but in hospital in Italy, we use the same criteria to make, for example, molecular diagnostics. The clinician normally call the laboratory if the child or the baby is not feel well, so high fever, for example, or particular parameters like PCR or Procalcitonin is too high. The doctor called the laboratory, and we perform, in case of a positive blood culture, we perform molecular diagnostics.
Right.
Now some laboratory try the new technique for starting from the not the blood culture, but the blood samples, but the indication is not so easy. The clinician that must be respected SOFA criteria, for example. I don't know if I am clear or
Yeah,
not.
no, I understand. I also had a question about microbial resistance, and you talked about that too. How can this type of diagnostics be an advantage when it comes to that aspect of antimicrobial stewardship or antibiotic stewardship?
But this technique help the clinician to choose the antibiotics in particular, and molecular techniques give us some indication about which kind of treatment. So
right. Yeah, exactly. Yeah, but that's good. You also talked about high costs. So how can we, if we put it on, it's one thing in Italy, but if we talk on a sort of a global aspect, how can this be used and not being so with such high costs? Is there possibilities to develop that in a way that it can be used also in low and middle income countries?
yeah, it's not simple because
No,
I hope in the
no,
future,
it's not a simple
but
question.
actually it's not the high cost is is normal. So
Yeah,
for
okay.
example, for the blood sample, for the sequencing, the cost is normal because
Okay.
you need a particular instrument, but in particular specialized technician and microbiologist. So
Right.
okay.
Well, thank you so much. I'm going to just check the chat here a little bit, see if we have any questions. Yeah, that's to Chiara. Too many challenges with the use of blood culture, even when we use the multiplex DNA sepsis flow kit. Which more rapid diagnostics tests do you recommend? POC tests do you recommend for low resource setting? Yeah, that's a difficult question too.
Difficult question. I don't know how we use the Biomarker, but it's not low cost. So it's low for it depends to the hospital and the region, so the country. It depends. I don't know which technique I can suggest. I don't know.
No. I'm not quite sure who this question is for. After how many hours result shows the report finding? Could that be you, maybe, Chiara? I guess it is because you were last.
Sorry, can you repeat?
Yeah. After how many hours the result shows the report finding? I'm not sure what they mean about that.
Probably when the blood culture became positive after.
Yeah, maybe.
If the laboratory work 24 hours, after 1 hour, the blood culture became positive. After 1 hour, you can have the answer, but it depends to the technique. For example, if you use WGS or other Sanger sequencing, probably is 60 or 8 hours. If you use fast microbiology, like for example, Biomarker or other techniques that I show, but I don't show everything in the every technique available.
No, right.
Is in medium 1 hour, 2 hour maximum.
Yeah. I have a question for you, Amy, if you are still with us. I think you are. Have you sorted by sex? Do you think there are ethnical differences in these gene signatures?
Yeah, that's a really good question. I'm not sure how sex is, ethical consideration or ethnical?
No, ethnicity.
Okay.
Yeah.
Ethnicity.
If there's ethnicity
Okay.
differences, yeah.
Yeah, so I'm not so because it's a small sample size, we didn't separate for that particular analysis. We didn't separate them by sex. In the Gambia, there's definitely diverse ethnicity in there. And again, because of sample size, we're talking about 18 infants, right? 16 to 18 infants. It's really too small for us to stratify into the diverse ethnicity to find that marker. What I will say is we're working on the larger cohort to try to develop strategy that take into consideration of the dynamic nature of how much molecular change occurred during that neonatal period. And I think Dr. Gleeson kind of mentioned it briefly. And then the other aspect that we're trying to do, and this is where we're incorporating sex into this understanding, is that we know, for instance, male neonates are at increased risk for developing sepsis and have worse outcome, right? And so some of these future analysis with the larger numbers will incorporate that those covariates just with the power calculation.
Thank you for that great answer. I can't find any more questions in the chat, but if there's anyone in the panel who would like to add something at this point, the mic is free. Or if not, we thank all of you for sharing your fantastic presentations, and also for all of the people who have joined us from all over the world to listen into this conversation around diagnostics and diagnostics and biomarkers in women, children, and neonates. And we are really happy that you all have been watching, and I thank you all, both the speakers and the viewers, and I hope that we will see you in the next session also. Please stay tuned, because there will be much more from the World Sepsis Congress. Thank you all for participating.
Thank you.
Yeah.
Bye.
Bye.
Bye-bye.
Thank you. Bye-bye.